you have to identify or maybe outline the cause of male and female infertility and the diagnostic criteria and management or treatment modalities of infertility. So it is actually a very short session we will be having today. Then how do you define infertility? So infertility is medically defined as inability to conceive, like after 12 months, like or after 1 year of unprotected sexual intercourse. So that is when we say, like, if they are not able to conceive after this period of unprotected intercourse, we call them, they are most likely having infertility and they have to undergo screening and supportive therapy. Then infertility can be either primary or secondary. So primary stands for infertility following, prior pregnancy. Secondary infertility is following at least one prior conception. So there is a possibility for a mother or a father to be infertile after one prior conception. That is when we are going to say secondary infertility. So how is the epidemiology of infertility? Despite I didn't manage to get any data in African population, but according to the epidemiological studies in the US, in population less than 60 years old, infertility ranked like the fifth highest serious global disability, and it affects like 10 to 15% of reproductive aged couples. So that is when you are going to see the possibility of infertility, like this age group is the mostly affected age group. Then what are the etiologies? So when you look at the etiologies of female infertility, it is related to abnormalities in menstrual function, especially in females. Abnormalities in the menstrual function constitutes like the most common cause of female infertility, specifically like ovulatory dysfunction, maybe any problem in the uterus or any outflow obstruct. Those are the major causes of fertility in female population. Then in male factors, like what are the factors that can actually affect a male pattern infertility? Maybe it could be a primary testicular disease that affects like the testis, which is the principal organ in male to produce sperm. Then it could be a genetic disorder, or it could even a problem in the transport of the sperm. And not only even transport, but also even reduce the number of sperm count is also another possible risk factor. Or it could be even hypogonadism as a result of a disease from the hypothalamus and pituitary. There is a possibility of having that problem. Then, when you look at the causes in summary, like the female causes account is like 38% of the causes of infertility, and male pattern accounts is like for 20%. So that means when you are actually when a certain couples are undergoing a screening, like both partners are supposed to undergo screening because it can be either in the female or it could be in the male, but mostly the causes are from the female side. Then around 50% of infertilities are caused by unknown causes. Like all the parameters are like the gonads, like the hormone, and everything is actually normal, but they are not able to conceive. So no one knows like what really causes. Well, we call it like an unexplained cause of infertility. When you look at the female causes, it could be ovulatory dysfunction, accounts like the significant proportion, like 32%, but it can be due to a tubal defect, it can be endometriosis, what we have seen, it could be even other factors. So ovulatory dysfunction can be a problem in the hypothalamus, it could be even a premature ovarian failure, it could be any problem in the uterus of outflow obstruct disorder. Then, in case of male, it could be like primary hypogonadism. Of course, most of the male pattern causes are unknown. They are idiopathic. Like around 40 to 50% of infertility in female is usually unknown. But it can be due to primary hypogonadism, it could be secondary, it could be even a disorder in the sperm transport, which accounts as like 10 to 20% of fertility in female, sorry, in male. Then when you look at the primary hypogonadism, so remember when you say primary hypogonadism, the problem is the reproductive organs or the gonads. So as a result, what will happen? The follicle stimulating hormone will be elevated, like, or the level in the serum will be very high in case of hypogonadism, specifically in the primary hypogonadism. In the secondary hypogonadism, since the problem might be from the anterior pituitary, now the FSH and the luteinizing hormones are usually very low. So these are indicators of secondary hypogonadism. So those are the preliminary like assessment in investigating infertility. They are going to check first about the hormone level. Then after that, then they're going to actually investigate further. Then is it possible to prevent infertility? Yeah, most of the time it is very hard. It's very hard to prevent infertility. However, some conditions are actually responsible to increase the risk of infertility. For example, weight extremes. They have been associated with infertility and they're responsible to cause an ovulation. So they are not able to ovulate the egg from the ovary to the fallopian tube, ready to be to undergo fertilization. So in general, healthy lifestyle is very important. If someone is overweight, they are supposed to reduce. If someone is underweight, they are supposed to actually have optimal healthy lifestyle because it affects the normal menstrual cycle or ovulation. Then another substantial factor that can increase risk of infertility is smoking. So smoking can affect both parties, especially in male. It can even reduce the concentration, the number of sperm count. So in general, it can affect the semen parameters. So remember, when you say semen parameter, it refers to like the sperm count, motility, and shape and ability to penetrate the egg. Those are the factors that are supposed to be affected when someone is a smoker. So, and those couple were supposed to give proper advice about the risk of smoking and fertility. Then, moderate alcohol and caffeine consumption has no adverse effect on fertility, but especially alcohol is not generally recommended during pregnancy because it can cause fetal alcohol syndrome. It's just like a facial anomalies as a result of alcohol exposure during pregnancy. Then, however, the higher the exposure of the alcohol and recreational drugs, like the higher the risk of infertility. So, generally, a higher use of recreational drugs and alcohol is not recommended. Even like the desire to have intercourse is usually reduced when someone is actually addicted to recreational drugs. That one we'll discuss it in detail in the next semester when we're dealing about the CNS and psychiatric disorders. Then, how do we investigate this condition? So, the primary focus of investigation is like determining what are the causes of infertility in both in female and female, male and male, male and female. So that is a major thing that is supposed to be given priority when we are investigating infertility. Then remember, history is very, very important, especially in assessing fertility. So you need to ask adequate medical history. For example, like any congenital abnormalities, any problem in the testes. So this is testicular examination. Usually is supposed to be done when you are suspecting infertility. Then you need to ask whether any prior paternity. That is very, very important, whether it is like a primary or secondary infertility. Then apart from that, we need to ask about like how frequent the intercourse is and how is actually like the timing of the intercourse. Like the timing in a sense that is it like toward the end of like toward the time of ovulation, that is usually which occur mostly around 14 days of the menstrual cycle. That is when we are expecting ovulation in a majority of the female population, especially when they are having regular menstrual cycle. But it can be before 14 days, it can be even after 14 days. After 14 days, so it is very hard to estimate the possible ovulation period unless you do a test. Even that test might not be accurate, but I will come later. Then exposure to toxin. Remember, some toxin can actually even can affect the gonad. So the gonad is no longer able to like produce the desired hormone, which is important for ovulation. Then previous surgery, like any surgery that can cause trauma to the reproductive organs, are also responsible. Drugs and medication. Some drugs that actually even cause like gonadal damage, especially the anti-cancer medication. By the way, when someone undergo chemotherapy, either male or female, the probability of fertility after chemotherapy is very minimal. It is very minimal. In principle, they are supposed to stay at least like 2 years after chemotherapy if they want to have a desire. I think that one will come when we are discussing about like cancer. Huh? When are we going to expect like how long is the duration of normally like expect how long after the chemotherapy they're supposed to consider conceive if they are able, but it is very minimal. But usually 2 years is actually expected, but uh, uh, I will discuss in detail why 2 years. Okay, then general health condition like diet, exercise, any review of system. So this one will give us a clue at least what kind of investigation or lab test we are going to consider. About the female factor, look at in the history of the pubertal development and any contraceptive history. Yeah? You know, some contraceptives, especially like the long-acting contraceptive, it will take even like sometimes longer time to resume the normal menstrual cycle. So you can actually even ask, like the mother, where they have been on contraceptive before and etc. This the effective contraceptive and etc. And we have to look at the washout period. Then prior pregnancy and outcome of pregnancy. Yeah, sometimes some condition such as antiphospholipid syndrome, they can actually causes recurrent abortion. So there is a possibility of having that condition. So we need to ask any prior pregnancy. Then previous surgery, especially in the pelvic area, sir. So we need to ask in case there is like any problem as a result of the surgery. Drug and medication, as I mentioned before, specifically for anti-cancer medication, and look at the general health of the patient or the person. Okay, those are the kind of things we need to ask from the history component to assess infertility. Then the next step is after getting all those information, the next step is like laboratory investigation. So in the lab investigation, especially for male infertility, we are going to look at the semen analysis. That means we are going to take like a sample of the semen, maybe after like taking from masturbation, or maybe like after like coitus interruptus. This is just like interruption to take like the fluid. But this is the most common method. This one is the most common method to take a sample of the semen. So remember here, the normal semen analysis we're actually referring to assessing the level of testosterone, and the normal value is usually like above 20, above 20 million per ml. That is the normal count, and the motility is usually above 50% when we say normal. So anything that affects the count and the motility can actually even affect the possible like the possibility to actually to conceive or to for the mother for this guy to impregnate a woman, the probability might be very minimal. Then sometimes even you can check the serum level of testosterone can also be done in the other male hormone testing. I think those two tests are the most common one. Then apart from that, maybe we can check a biopsy, like from a biopsy from the testis. So this one is just like to assess any abnormalities that affect the infertility, as well as even to retrieve sperm for in vitro fertilization. So I don't know how frequent this procedure is, but there is a possible option. And apart from that, even we can consider even what they call vas different or vasography. So this is just like scrotal ultrasound. So in this procedure, we are going to look at actually the duct that transport sperm from the testis to the seminal vesicle. So if there is like any blockage in the vas different, it will give us like this anatomical obstruction, the one which is responsible to cause for infertility in male. In fact, vasectomy is one of the permanent like method of contraceptive in male. Yes, as long as you tie that one, the probability of passing of the sperm from the testis to the seminal vesicle is very unlikely. Yeah, very likely to happen. So that means in this case, you have to look at whether there is any obstruction about the vas different, which is a tube that is used to transport the sperm. So those are the investigation parameter we are going to consider to assess whether a male is actually fertile or not. Then, when you look at the investigation parameter to be considered to assess female infertility, the first one is ovulation testing. In fact, it is very hard to time or to know the exact time of ovulation, but this is just like estimation. Huh? So this one refers to a blood test. It can be even a urine test to measure the hormone level to determine whether like a lady is ovulating or not. Huh? So most of the time, like toward the ovulation time, there's luteinizing surge. So in the urine test, it's just like a pregnancy test. We are going to assess whether positive or not for luteinizing hormone surge. So if it is positive, means like the mother is most likely ovulating. So this is just like to assess whether the mother is able to ovulate or not. So in general, you have to actually take a sample of like, or you have to take the test like 3 to 5 days prior to the expected date of ovulation. Despite it is very hard to estimate the exact date of ovulation, but the majority of the regular menstrual cycle ladies, the ovulation time is usually like around 14 days of the menstrual cycle, around like mid-month. Okay, so this one you can actually even assess the luteinizing surge. Okay, then the second one is hysterosalpinography. This one is just like it's just an imaging to assess the condition of the uterus and the fallopian tube. You look at it imaging, but I don't know how frequent this is. Then the next step and the most common one is ovarian reserve testing. So this ovarian reserve testing is usually to assess the quality and the quantity of the available eggs like for ovulation. So most of the time, they are going to check the level of follicle stimulating hormone, the estradiol, and also anti-Mullerian hormone. Anti-Mullerian hormone. So if the follicle stimulating hormone is actually very high, means most likely like that mother is actually having a problem of primary hypogonadism. Like that means like the FSH is actually very like, or the anterior pituitary is overstimulated to stimulate the like the mature or to stimulate the follicular development. So usually high value of FSH is actually tells you the egg reserve is very few. Then even anti-Mullerian hormone is also another hormone that can actually even assess the ovarian reserve. So the higher the number, usually like higher number indicators or higher value indicators, like the egg reserve in the oval is actually very adequate. So those are the common tests to assess ovarian reserve, especially to quantify or to estimate the quantity of the egg available. Then other test which is most commonly done is pelvic ultrasound. So I don't know whether anyone who has done this procedure before, when someone is complaining in the pelvic areas, especially for ladies, when they're actually complaining any pain in the pelvic region, most of the doctor they usually recommend to do pelvic ultrasound. So pelvic ultrasound is more of looking the reproductive tract in the pelvic region. But when you say abdominal ultrasound, it's just like looking the upper part of the abdomen. But when you say abdominal pelvic means you have to look at the upper part of the abdomen and the pelvic region. But abdominal is usually to see like the liver, the kidney, maybe the yes, those organs in the upper part of the abdomen will be usually seen by abdominal ultrasound. Okay, then remember, if you want to see the pelvic organ, like the person who is going to conduct the procedure is supposed to take adequate amount of water until the bladder is actually full. Most of the time, you cannot see the pelvic organ unless the bladder is actually full with like water. So you have to take adequate amount of water until you feel tense. Huh? Otherwise, it is very hard to see like those pelvic organ. Okay, then those are the investigation parameter we're supposed to consider. Then how do we treat fertility, treatment of infertility? So the approach will depend on, you have to, like in all couple presenting with infertility, the initial evaluation will be, you have to like openly discuss about the timing of the intercourse, as well as the possibility of having modifiable risk factor like the smoking, alcohol, caffeine, and obesity, because they can actually have some effect on the fertility. So after that, you do the test. Then maybe the next step is providing proper treatment. So the treatment option usually progresses from the least invasive to the most invasive or use of donor sperm. So most of the time, treatment of infertility starts from like the least invasive or the cheaper or the cheaper infertility management, then in the most invasive and the most expensive one. So treatment of initial choice will depend on the concentration of the sperm as well as the motility. Yeah, because sometimes we can use even intrauterine insemination. That means you extract the sperm, then you directly place to the uterus. So like depending on the sperm concentration, the motility, like the treatment modalities usually varies. So the initial evaluation of FSH, luteinizing hormone, and testosterone, those are very important to rule out whether the problem is actually having any obstructive defect or primary hypogonadism or secondary hypogonadism. So this one is very important even to assess the evaluation. Then in general, in case of male factor infertility, if the sperm count is not very badly reduced, like if the count is between 15 to 20 million, and if the motility is actually normal, that is very mild condition. So expectant management with timed intercourse will work, but you have to monitor. Normally, the sperm count is supposed to be above 20 million in normal. So the higher the number, the higher the probability to penetrate and causes fertilization. That is why the count even usually matters. But not only the count, even the shape and motility is also very important. Yes. And apart from that, even the uterine environment. No, if the cervical mucus is not like able to allow the passage of the sperm to reach the fallopian tube, there's still also another problem. Then the next step is in the case of moderate male factor infertility. So when you say moderate, when the sperm count is between 10 to 15 million and the motility is reduced kidogo, then in this case we can consider intrauterine insemination. That means you extract the sperm, then you put it directly with a syringe. So this is, we call it intrauterine insemination. Or maybe along with intrauterine insemination, maybe you can give the female partner to induce ovulation, like give ovulation induction medication along with intrauterine insemination even can work. So both approach can actually, we can use either insemination alone or combination of both approach can work. Yes. But in case of men with severe defect, severe means like when the count is above less than 10 million and the motility is about 10%, that is when you are going to say the defect is very severe. So this condition, what you can do is consider in vitro fertilization. So in vitro fertilization means you actually even take like the matured egg from the female and actually the sperm from the male. Then you actually grow in a culture. Then after that, after fertilization, 3 to 5 days of fertilization, now you transfer for the embryo to the mother's uterus. So this is very expensive and very fragile technology. So the success rate is actually is might not be as such, but those are the most commonly used the most commonly used procedure. So intracytoplasmic sperm injection means they are going to see the microscope and they directly inject to the cytoplasm of the egg. So this one is a bit more of advanced technology in case of fertility management. Then in case of any defect, maybe consider surgery. If there is an obstructive defect, maybe consider surgery in case of any tumor that causes blockage. Then in case of hypogonadism, like if the person is having any hypogonadotropic hypogonadism, that is when you are going to consider gonadotropin releasing hormone administration or follicle stimulating hormone replacement. So this one can actually restore testosterone production, and ultimately, when we do have sufficient quantity of testosterone in the serum now, it can promote spermatogenesis. So in such a way, it can restore fertility. So when male infertility is not amenable, all those treatment modalities, now you can consider either donor sperm for insemination or in vitro fertilization. So those are the options. So like depending on the will of the patient, maybe you can consider donor, of if not, you try in vitro fertilization. So those are the options of treatment to manage male factor infertility. Then the next or the in the next few slides, we are going to discuss how we are managing female factor infertility. Remember, still we are going to use a stepwise approach from the least to the most invasive and expensive procedure. And most of the time, we are going to use, like you are going to induce ovulation with pharmacological treatment modalities. So we usually start with clomiphene citrate, then progress to ovulation induction with gonadotropin, and ultimately in vitro fertilization. So start with clomiphene citrate, then if not able to achieve, we proceed to gonadotropin, especially in the hypogonadism. If we are not able to achieve, that is when we are going to consider in vitro fertilization. That is why infertility treatment should be a stepwise procedure. So we do have pharmacological treatment modalities to induce ovulation. For example, remember induction of ovulation can be accomplished around 90% of the patient who is having a problem with chronic anovulation and normal ovarian reserve, but they are not ovulated despite the ovarian reserve is normal. But this one will be true in the absence of any other endocrine condition, such as hyperprolactinemia and hypothyroidism, because hypoprolactinemia can inhibit gonadotropin-releasing hormone from the hypothalamus and ultimately reduces the follicle-stimulating hormone and luteinizing hormone from the anterior pituitary, which is important for ovulation. Then in case of even hypothyroidism, by the hypothyroidism can cause infertility. How hypothyroidism activates the anterior pituitary to produce more of TSH. So this TSH is actually a potent stimulus to increase the level of prolactin. So ultimately, those hypothyroid individuals are having high level of prolactin, then suppress GNH, RH, ultimately suppress FSH and luteinizing hormone, and ultimately inhibit ovulation. So in such a way, in the absence of any endocrine abnormalities, we can actually, like with clomiphene, we can actually achieve 90% of ovulation. So most of the time, this agent is like the agent of medication for younger women of less than 36 years of age. That is the normal recommendation, but they need to have like the normal ovarian reserve to induce ovulation. Then, how does clomiphene citrate work? By the way, I think let me pause and ask you a few questions. Have you covered clomiphene or maybe anti-fertility medicine and the pharmacology part? You can consider what? Surgery. So surgery or surgical approach can be considered. In case of polyps, any tumors in the uterus like this, they can actually even block the possibility of implantation. Then any uterine septum, like any congenital anomalies that can divide the uterus in at the midline, that can actually even interfere with implantation as well as like the possible transport of the sperm to go to the fallopian tube. So in that condition, like the gynecologist will do surgical resection of the tumor, then that is how you are going to restore or treat fertility. Okay, then. So if pregnancy is not achieved with ovulation induction, with all above methods, now the next treatment modality of regimen is in vitro fertilization, followed by embryo transfer. So what does this assisted reproductive technology entails? So this one is very common, the most common uh, reproductive technologies, and most of the time it involves you stimulate the ovary, and most of the time they are going to administer synthetic follicle stimulating hormone like 40 weeks time. Then after that, that is just like to stimulate the ovary so that they can get more like quite a number of matured eggs. By the way, most of the time they usually retrieve so many eggs because fertilization might not be achieved with one or very few eggs from the female ovaries. So they have to stimulate then retrieve more. Then after that, they will actually take like the freshest sperm during the day of retrieval of the matured egg. Then they actually culture in a lab. Then after that, like they can actually even transfer the embryo after fertilization into the uterus 3 to 5 days after fertilization. So this is the most expensive infertility treatment. I think what I have seen from the literature, it can cost around 50,000 to 30,000 USD. So that is the cost of infertility, this IVF. And apart from that, despite you paid this amount, there is a high possibility of failure rate. So you have actually like wasted like 30,000 USD But if you are not able to conceive, that is really devastating, even economically. So that is the major problem with this in vitro fertilization. And this is like the whole aspect of stimulate the ovary, then they retrieve the egg, then after that they culture it, then after that they transfer, then like 14 days after, they can actually even check the pregnancy by looking the beta HCG. Remember, like most of the time for the HCG to be produced after fertilization, it will take like 12 to 14 days. Sometimes even it goes up to 20 days. Yes. So if the urine sample doesn't work, you take from the serum. If both doesn't work, maybe you give time and you check it again. Yeah, that is when you are going to be very sure because like depending on the individual difference, in some individual, it will take longer time to be produced. Because of that, ACG urine negative does not mean that you are not you are not pregnant. So there is a possibility to give time, yeah, for the detectable levels of ACG to produce in the urine or in the serum sample. So that is all about infertility treatment. Then there is also a possibility of unexplained infertility, as I mentioned before. So as I said before, an unexplained infertility means like the couple is having normal finding with all those lab tests. However, there is no like known causes. So in that condition, maybe you can actually employ observation with timed intercourse, maybe ovarian stimulation with or without intrauterine insemination, or maybe you can try even in vitro fertilization. Also, some studies support the use of clomiphene with intrauterine insemination for up to 4 cycles can also be considered. So those are the possible options. But what is very common, despite I'm not very sure about the practice in Kenya because I have never encountered, clomiphene is the most commonly used modalities of infertility treatment. That is the most common. So they try this one with the timed intercourse. If they don't touch it, I think there is no much as such what you can do because the other techniques are not commonly done in our setting. Maybe you can find out what is going on in Kenya, but I heard about in vitro fertilization is available in Kenya. Is it true? Fertilization. So you just assist them. If they refuse to do so, there is nothing much you can do. You just actually support like the couples, like psychologically. I think that's the only thing you can do. Okay, so what is the complication? What are the complications of infertility treatment? The most common complication of infertility treatment is multiple pregnancy. That is one. And as I mentioned before, like when you have multiple, like premature labor and delivery is very high, so success rate will be very low. Then apart from that, those infertility treatment, they can stimulate the ovaries and that limitly can swell the ovary and it becomes very painful. But really, it can actually even cause increased risk of bleeding or increased risk of infection. Yes, so the infection is most likely as a result of like the invasiveness of the procedure to do like minor incision to assist the technology or to assist the reproductive tract to conceive. So that is why there is a possibility of having infection. So this is all what I have about infertility in short. So now it is time to have a question and answer session. If you do have any question.